Vertebroplasty and balloon kyphoplasty for compression fractures. What's the evidence? Often new surgical techniques are developed based on sound mechanical principles and the best of intentions. However, unlike many other types of medical treatments, surgical procedures often gain popularity without firm scientific validation. Recently, an approach to recreate the structure of a vertebra after fracture has come under scrutiny, especially given its exponential increase in popularity. These techniques together are called augmentation procedures, which include vertebroplasty and kyphoplasty. You likely have encountered a question from a patient with a compression fracture about whether this is a good alternative to simply letting the fracture heal. Several publications this year may help answer this question. Prior to an evaluation of the literature supporting or not supporting this augmentation approach, let's review the general topic of vertebral compression fractures first. It's estimated that compression fractures occur in 8% of women older than 50 and 27% of men and women older than 65. Approximately 750,000 are secondary to osteoporosis, affecting over 28 million individuals in the United States. Approximately 35% of compression fractures in women over the age of 40 are due to early menopause. 30% are due to long-term corticosteroid use, 8% are due to hyperthyroidism, and less than 2% are due to malignancy. Let's take the time to quickly review the diagnostic clues that suggest compression fracture. First, a history of long-term corticosteroid use or age greater than 70 years is suggestive of compression fracture in patients with thoracic or lumbar complaints. But osteoporosis is not the only cause. Our concern for pathologic fracture due to cancer and other processes should be raised for patients who are older than 50 years, have a past history of cancer, or have unexplained weight loss. On examination, there's often a sharp kyphotic angle at the area of fracture, and the patient will have pain on percussion and deep pressure over the involved segment. Yet the diagnosis is essentially radiographic, especially visible on lateral views. Generally, an anterior step defect is the most common sign. Remember also that a vertebraplana shape or pancake vertebra with both the anterior and posterior aspects collapsed is not typical of an osteoporotic compression fracture and would warrant further investigation into a cause for a more serious etiology. Loss of posterior vertebral body height without a history of trauma should raise the suspicion of pathologic fracture, warranting a search for metastatic cancer or multiple myeloma. An additional concern is stability. Collapse of the anterior margin to less than half the height of the posterior margin or a greater than 20-degree wedging may indicate an unstable fracture. Other indicators are based on the Dennis criteria. Using a three-column concept, if two or more columns are disrupted, the fracture is considered unstable. Also, the three-column approach may help differentiate between compression fractures and burst fractures. Compression fractures generally would affect only the anterior column, while burst fractures would affect both the anterior and middle columns. The three columns are the anterior column from the anterior longitudinal ligament to the midvertebral body, the middle column from the midvertebral body to the posterior longitudinal ligament, and the posterior column from the posterior longitudinal ligament to the supraspinous ligament. A general rule of thumb, both from a radiological and symptomatic perspective, is that healing of non-complicated fractures should be evident within about 3 months. So what are these new procedures and their proposed effects? There are two minimally invasive procedures designed to fill the gap of the fracture and/or increase the height of the collapsed vertebra, and they've been utilized for a number of years now. These procedures are performed by an orthopedic surgeon or an interventional radiologist and are generally outpatient procedures using a local anesthetic and minimal general anesthetic. The first procedure, called vertebroplasty, involves the injection of cement, usually polymethyl methacrylate, PMMA. Its use began in 1984. There are two intentions: to fill in the gap and potentially relieve pain in those that fail conservative management. or to restore the height of the vertebra and diminish the degree of kyphosis segmentally and across segments to improve cosmetic appearance. Your first introduction to vertebroplasty may be this finding on an X-ray. This represents the cement that's been injected and remains in the vertebra. With the introduction of the next advance in 1998, balloon kyphoplasty, there was a focus on the second intention, to restore the height of the vertebra and diminish the degree of kyphosis segmentally and across segments to improve the cosmetic appearance. This is accomplished by inflating a balloon in the vertebra to create a space into which the cement is injected. As of 2011-2012, as many as 70,000 to 100,000 procedures were performed each year. In the United States, vertebroplasty costs around $3,300, while kyphoplasty costs around $8,100 when performed as an outpatient procedure. When performed as an inpatient procedure, vertebroplasty costs around $11,000 and kyphoplasty around $16,000. In 2011, Medicare spent about $1 billion on these procedures. Well, it seems like the popularity and utilization would be one indicator of support for their success. So what would be the patient's concerns? Well, first, pain. When will the pain go away? Secondly, cosmetic deformity. Can I avoid being hunched over? And third, can more fractures be avoided? And they'll ask, it's the newest scientific breakthrough, so why wouldn't I get it? So what does the literature say? Well, ironically, even studies that support vertebroplasty state, quote, most patients with osteoporotic vertebral fractures are treated successfully conservatively by means of pain medication, bed rest, physiotherapy, and/or a cast, unquote. Other recent statements in several studies cast doubt while still seeming to support these procedures. For example, quote, it could not yet be established with certainty that height gain and improved realignment are clinically relevant, unquote. Quote, there is still a lack of randomized trials focusing on long-term results in vertebroplasty versus balloon kyphoplasty and showing a significantly better outcome due to restored spinal alignment, unquote. Quote, due to the poor quality of the evidence currently available, high-quality RCTs are required, unquote. So why this dichotomy between the literature and the statements made by the same authors and clinicians? Well, like all matters, it's the complexity. There are many factors to consider in different patient populations. For example, what are we talking about in any given study? Is it about pain, deformity, prevention, future occurrence, cost, safety, comparison to natural history or other treatment, or a comparison to a sham treatment? So when making comparisons related to effect, often authors are comparing apples to oranges, or worse yet, making no comparison to natural history or a sham comparison. In many studies, patients are not randomized, opening the door for selection bias on the part of the patient. And finally, many of the studies, including the RCTs, are funded by the companies that manufacture the devices and substances used in these procedures. So let's make an attempt at looking at the sequence of studies and what issues they raise and conclusions they reach, and then discuss some national recommendations and follow with a sensible care pathway for patients with osteoporotic vertebral compression fractures. The first caution was raised by a study published in 2009 in the New England Journal of Medicine. It's entitled, A Randomized Trial of Vertebroplasty for Osteoporotic Spinal Fractures. They revealed a common dilemma. What if both a sham and real procedure work similarly, but better than natural history or conservative management? An interesting problem, because ethically we're told that if a sham treatment works as well as a real treatment, neither should be utilized. From the patient's perspective, though, they both work and probably they don't care if it's real or not if they get relief. But there is the ethical problem of using a sham treatment without the patient's consent, a curious catch-22. Then followed several RCTs. We'll review this one titled Balloon Kyphoplasty for the Treatment of Acute Vertebral Compression Fractures, 2-year results from a randomized trial, published in the Journal of Bone and Mineral Research in 2011. The treatment difference remains statistically significant between a kyphoplasty group versus a conservatively managed group at 6 months, but not at 12 months and not at 24 months. The difference between surgical and non-surgical management are statistically significant when averaged across 24 months. Most outcomes are not statistically different at 24 months, but the reduction in back pain remains statistically significant at all points in time. More recently, several systematic reviews have tried to compile the existing evidence and come to some conclusions. This one is titled Vertebroplasty and Kyphoplasty, a systematic review of cement augmentation techniques for osteoporotic vertebral compression fractures compared to standard medical therapy, published in Spine in 2013. Their conclusions: kyphoplasty is not superior to vertebroplasty for pain. Kyphoplasty may be better than vertebroplasty for vertebral compression fracture reduction, and kyphoplasty is probably not cost-effective, and vertebroplasty has demonstrated only short-term cost-effectiveness. Their stated bottom line was that vertebroplasty and kyphoplasty cannot be recommended as standard treatment for osteoporotic vertebral compression fractures. Here's another titled Meta-Analysis of Vertebral Augmentation Compared with Conservative Treatment for Osteoporotic Spinal Fractures, published in the Journal of Bone and Mineral Research in 2013. They conclude basically the opposite, that the health-related quality of life measurement showed statistically superior results for vertebroplasty compared with conservative care. However, secondary fractures were not statistically different between these two groups. Let's review the findings of yet another recent study entitled A Randomized Trial of Balloon Kyphoplasty and Non-Surgical Management for Treating Acute Vertebral Compression Fractures, published in Spine in 2013. They conclude with the statement that compared to standard care, balloon kyphoplasty improves patient quality of life and pain averaged over 24 months and results in better improvement of vertebral body kyphotic angulation. As you might guess, several problems emerged with these augmentation procedures. One is the potential leakage of the PMMA that may result in neurologic compromise. This may occur asymptomatically or symptomatically around 2% of the time. Pulmonary embolism from injection into the venous system is also possible, occurring in 2 to 26% of procedures, and long-term effects are not known at this time. Here's an example of extravertebral leakage that can cause spinal cord compression and potential paralysis. So let's start to summarize. Certainly the first question is, are augmentation procedures better than conservative management? Well, randomized studies using control groups have not yet demonstrated a clinically significant difference between placebo and surgery, other than some immediate improvement differences in pain with the surgical procedures. Next, is vertebral height restored? The differences are often only a few millimeters, but they're reported as percentages of around 30%, so these seem impressive, but cosmetically not necessarily significant. And no studies have demonstrated that there is a prevention of further fracture, and in fact, in some studies, an increase in adjacent level fractures. Initially, one goal of these new procedures was to reduce new fracture occurrence. So do these new procedures actually reduce new fractures? Well, the reported new fractures after balloon kyphoplasty and vertebroplasty varies from 11.25% to 26%, similar to natural history. The rate of adjacent new fractures ranges from 18% to 90%. The debate continues, and heated at times, with significantly different interpretations. The American Academy of Orthopedic Surgeons in 2010 recommended against the use of vertebroplasty. Other groups, such as the Australian Medical Services Advisory Committee, recommend its use for those who have failed conservative management. Others recommend its use for vertebral fractures other than osteoporotic compression fractures, such as those due to cancer or other disease processes. So, are there any newer techniques that circumvent the concerns of the older techniques? Well, augmenting devices such as KIVA are being tested to better restore vertebral height and avoid leakage. These devices are usually implants, often columns formed by coils to form an intravertebral housing for the cement to be injected into. Here's the most recent study on KIVA entitled Balloon Kyphoplasty versus KIVA Vertebral Augmentation, comparison of two techniques for osteoporotic vertebral body fractures. This was published in Spine in 2013. So is KIVA better at kyphosis reduction? Well, residual kyphosis of more than 5 degrees was measured significantly more in the balloon kyphoplasty than in the KIVA subjects. That means more kyphotic angulation in those receiving balloon kyphoplasty. KIVA had significantly lower extracanal leakage rates compared with balloon kyphoplasty. The advocates of these procedures argue that these procedures reduce pain and disability far quicker than natural history, which allows mobility. If patients are immobilized by the pain, they're more likely to develop other problems. So basically, pain relief sooner than later is better versus making long-term comparisons to natural history. To be frank, chiropractors often use the same argument regarding the treatment of low back and neck pain, which tends to improve faster with chiropractic care compared to natural history, but no difference in long-term follow-up. So now, how to apply this new information in light of unanswered questions? Well, patients with infection, primary tumor or metastasis, unstable fracture, and complications due to corticosteroid use should be referred for medical evaluation and possible management. Patients with uncomplicated compression fractures will probably have pain for 1 to 2 months during the healing phase. Bracing or restraint in the thoracic region is not recommended because of its effect on normal breathing. Failure of conservative care or concerns about prolonged immobilization warrant a consult for surgical correction. So the take-home points? Don't rush to a new treatment approach if it is no better than natural history, no better than a sham treatment, not cost-effective, and there's higher risk with no clinically significant benefit. Like all procedures, it's likely that these augmentation procedures are valuable in a subgroup of patients, including those failing an initial trial of conservative care, those at risk for prolonged immobilization and its attendant problems, and those with more complicated health issues and fractures not due to osteoporosis. The bottom line, as usual, is this is the patient's decision. But as a patient advocate, we can advise our patients on the evidence and encourage them to become more informed prior to agreeing to these procedures.